iron is such a toxic element. Everybody should know their iron status, their iron levels.
Okay, so welcome back to the TRT and Hormone Optimization YouTube channel. And back with us is Dr. Rudy Eberwein. Welcome back, Rudy.
So happy to be here, Stephen. Always a good time together.
Welcome back. And a few weeks ago, we talked about iron overload and ferritin levels. And you asked me to send you my most recent blood results. And let's talk about those first. And what does it all mean?
Definitely. So I received your iron levels, and again, you gave me permission to go over that, so no HIPAA violation. And that is something important that for people listening to this, I'm pretty sure most people did not get their iron levels tested unless you ask for it specifically. They won't test it, and sometimes they'll test just the iron and CIBC, and they won't test the ferritin. So I'd like everybody listening here, and then I'll make my argument why this is important. Everybody should know their iron status, their iron levels. It is as important, if not important, than knowing your cholesterol level, your blood glucose level, your hemoglobin A1C, your HSCRP. So iron level should be part of the biohacking, age management, anti-aging biomarker panel because it has such an influence on chronic diseases. And as I'm going to prove to you, longevity. Right? Those lab tests that you did, is that the first time you ever had your iron checked?
No, I have it checked each year.
Very good. And that's again because you know this. I only started checking iron about a year and a half on my patients. And I'm going to tell you why I started checking iron levels. It was mostly because some guys were over donating blood and they were dropping their ferritin. So I went there looking for low ferritin levels, but I found mostly high ferritin levels or higher than normal ferritin levels. And this is where I started really doing a deep dive into understanding iron physiology, understanding the relationship between iron and testosterone and chronic diseases overall. And this is what we're going to talk about today. So to start off,
before you go over my blood work, I must first share with the viewers that, of course, I'm on TRT and I've never donated blood, Rudy. So that I want to share.
Good. And your levels show that really your levels are pretty good. So you sent me a compilation of your labs. Do you have them with you by any chance?
No, I don't.
No,
have
I
them
remember.
here.
So your iron level was 75, which was within normal limits. Your transferrin or iron saturation was 26%, which is within normal limits. Usually we want it between 15 or 20 up to 50%. Between 20 and 45 would be ideal. And your ferritin, which is what we're going to spend a lot of time talking about, your ferritin level was 140. Normal ferritin on most lab ranges, for example, LabCorp in the US that we're using, the normal ferritin level are 30 to 400 nanogram per milliliter. And that's for men. For women, it's from 20 to 150. But we're going to speak mostly about men. And when I speak about iron deficiency, I'll talk more about women. So normal ferritin on paper is 30 to 400. Kind of reminds us those big ranges about like what testosterone is at, right? Very big ranges. When you have a big range like this, you want to think, what's the significance of this? So ferritin basically is the iron. It's a storage molecule for iron. It is where iron gets trapped, whether it's in the liver. So it's not, and it is trapped in its ferric form, the less toxic form of iron. So it doesn't cause, so the body really envelopes the iron molecule so it doesn't cause damage. That's how it gets stored in the liver. Then it gets transferred into the blood test where it's being circulated via transferrin molecule.
Right.
So what's important for ferritin to know is that it both reflects iron stores and also inflammation, because it is what we call an acute phase reactant, meaning that if there is inflammation or infection, it will go up. So ferritin and iron have a very close relationship. Our blood tests are not perfect, but that's what we have. So we have your total iron, your TIBC, and your total iron and TIBC, your transferrin saturation, and your ferritin. We also have your hemoglobin and hematocrit. Your levels were 60 and the hematocrit were 50. And you had an MCV, mean corpuscular volume, at about 89. Normally between 80 to 100. So all of your normal numbers are within range. But when we go deeper and we're going to focus on ferritin, your ferritin is not in the optimal range. And what do I base myself to say that? There was a really interesting study. It was called the FEAST, F-E-A-S-T, the FEAST study, iron, Fe, in atherosclerosis study. And that was done, a study that was done in the late 90s. It was done out of about 24 VA centers, about 1,200 patients that they followed for 6 years. And those patients had peripheral arterial disease. They had clots, they had plaque in their legs, arterial insufficiency in their legs. So those were kind of patients with atherosclerosis already, so high risk type patients. And what the hypothesis was, because they know that iron interacts a lot within the atherosclerosis plaque. So the hypothesis was by donating blood, they would improve the outcomes. So they followed about 1,200 patients. Average age was about 60 for about 6 years. And they were doing phlebotomy on those patients to decrease the ferritin. And the results were very interesting. So when they first published the results, they saw that there was no influence of decreasing ferritin with outcomes. And they looked at two outcomes. The first outcome was death. The second outcome was non-fatal MI, stroke. So whether you die, you had a heart attack, or you had a stroke. Those were the three outcomes they looked at. So it was kind of discouraging to see that, wow, okay, you donate blood, we had a good hypothesis, it didn't work. But in 2007, those that was late 90s, they reanalyzed the data and they found something very interesting. They said that if they account for age, the younger patients, so younger was the age 43 to 61, had a significant improvement in their peripheral arterial disease and in the primary and secondary outcomes, which was death, heart attacks, and stroke, the lower their ferritin got. Okay. It was so powerful that in 2011, in the magazine, a very famous cardiology magazine, Heart Circulation, they put out those findings that then when they reevaluated the data of the FEAST study, they showed that for younger patients, that's 43 to 61, graded phlebotomy and bringing your ferritin level between 20 and 100 completely improved all of the outcomes. Less incidence of death, less incidence of heart attacks, less incidence of stroke, and better results with their peripheral arterial disease. And that is not the first study they did on ferritin and longevity. There was another study that was done in Finland. Those are in younger patients, 38. And they saw also that there was a direct linear correlation with ferritin and longevity. And the last study that they did, I talked about this in our last one, was a Scandinavian study. It was the Copenhagen Heart Study. And they looked at almost 10,000 patients for 23 years. That's a big study. And they looked at a stepwise increase in ferritin corresponds with a lower survival age. This was very simple. And what I liked is they didn't say why your ferritin was elevated, but a high ferritin level was associated with an earlier age of death. People who had ferritin 500 or more, the average age of death was in the 50s. If you had 200 or less, it was 79. That is a big difference. And it was a linear. That's why they feel, and when they look at the FEAST study, they're like, okay, less than 200 was with the Copenhagen Heart. The FEAST study showed that it needs to be even lower. So now, if you look at every functional medicine recommendations based on the FEAST study, is that they want the ferritin to be between 20 and 100. In that study, the FEAST study, they looked at a ferritin of 194, positively correlated with higher risk of heart disease, higher risk of stroke, higher risk of cancers, because ferritin and iron is a carcinogenic that I'll do a talk about this to explain how it is a carcinogen. So if I look at your numbers, all of your numbers are good. Only your ferritin is a little bit outside, above the above the optimal functional medicine range, which would be between 20 and 100.
Okay.
Now, why would you donate if your levels are quote unquote normal and you have no symptoms from it? And that's the big question. Again, those studies show us that a lower ferritin level corresponds to to better outcomes overall. And why is because iron is such a toxic element. We've talked about this, how iron is necessary for life. It is necessary to carry oxygen level. It is necessary to catalyze reactions in the electron transport chain for the formation of ATP within the mitochondria. It's necessary for brain development, muscle development, very important in your immune system. So iron is necessary for life. There's no question. But too much iron, and again, it is because of its oxidative properties, the fact that iron can give electrons, that's how it can create ATP. It creates a lot of junk and rust. So what I'm trying to make people understand is a very simple concept. Iron rusts metals outside. Everybody can see that. Iron also rusts our cells in the inside. So I want you to picture when you have too much iron, it's almost like you left a metal chair outside and you start seeing that it starts getting rust. And with time, the rusting goes deeper. Eventually, it disintegrates the metal. What iron does to our cells, it causes the formation of oxyradicals, reactive oxygen species. And oxyradicals are the most destructive oxidants, right? We always know that we have to take antioxidants to prevent aging. Well, how about decreasing the formation of oxidants with iron? So when we manage our iron status, that's what we do. We try to decrease the amount of oxidants that we create. Because the way cellular respiration happens is oxygen comes in, goes through the electron transport chain, creates ATP, but by creating ATP, the other side of the coin is that it creates oxidants. It creates fumes, exhaust, right? It's like a car. You create energy, but your car creates exhaust. Managing the exhaust is one of the most important things we need to do in anti-aging or age management medicine. So yes, you want to make more ATP, but you want to also deal with the exhaust. And the exhaust is the oxidants formed by cellular respiration. When they combine with iron, and especially they call it non-transferrin bound iron, when iron is not bound to molecules like transferrin or ferritin, it becomes free to rust our cells. You combine hydrogen peroxide, which is a byproduct of cellular respiration. Hydrogen peroxide plus oxygen via the Ferritin reaction causes one of the most destructive radicals known. It's called OH minus. The Ferritin reaction causes that radical that can destroy DNA, so causing cancer, malformation, can destroy lipid, causing lipid peroxidation. It interacts with atherosclerosis plaques, increased risk of heart disease, peripheral arterial disease, can denature protein. So this reaction is one of the most important reactions we need to know about, the Ferritin reaction. So based on knowing that iron is a very potent oxidant, that's why we want to keep your ferritin level at that range.